Hi, I'm Kevin Buda, a general cardiology fellow at Minneapolis Heart Institute and Hennepin Healthcare, and an incoming critical care fellow at Mayo Clinic. I'm here with Dr. Kenji Inoue, who is just in a few hours going to be presenting a late breaker at the American College of Cardiology about a 0-1 hour algorithm for chest pain in emergency department patients, a multicenter Asian study. And so, Dr. Inoue, first of all, I know you're a very busy man, so we really appreciate your time. We appreciate you being here.
Thank you too.
And I was hoping you could start us off with just starting by what was the reason for doing this study, what was the purpose of the study, and what did you find?
Yeah, thank you for your asking. Actually, this algorithm is quite easy to understand because it just appears at just numerical number twice of the troponin data. And then if you understand the reason, and if you understand the result, you can stratify the patient easily. I mean, for cardiologists, honestly speaking, 0-1 algorithm is not so important because you are a cardiologist. You can identify the patient whether high risk or low risk. But I mean, most important, doctor is just a resident or non-cardiologist like a ED physician because they are attend the patient during the night. That is why for them, 0-1 algorithm is really good for them. That is why I just conducted this study, especially in Asian countries. The reason why we conduct in Asian country is just compare the European or US. Actually, the system to take care of the patient is not so integrated. It really depends on each countries because, as you know, in Asian countries, very variable and different region, different healthcare insurance system. That is why we cannot integrate the system to take care of the patient with the chest pain. That is why it is another reason to conduct this study.
And can I ask, before we get into the study results, the sites that were involved, were these large tertiary, quaternary care centers? Was it a mix of larger institutions and smaller community hospitals? Right. Who was actually involved in the study?
Basically, actually, we asked 12 hospitals to enroll this study, and 2 institutes do not have. One institute is just a local hospitals, not tertiary hospital. One hospital do not have a cath lab, but another one just, as you say, a tertiary hospital and of course have a PCI facilities.
Okay. And you mentioned troponin. There's a lot of data, contemporary data on high sensitivity troponin assays and improved outcomes and ability for early discharge with high sensitivity troponin assays. Were these high sensitivity troponin assays that were used throughout all of the sites, or was there variability between the different centers?
Thank you. At first, 1 to 3 institutes did not have a high sensitivity assay system. Just a POC, point of care testing. So during the usual care, they used it. But after the implementation of the 0-1 period, all institutes used a high sensitivity assay system, especially the cardiac troponin T.
Okay. And that's a great segue into the design of the study. So can you tell us the design before we start talking about results?
Yes.
Please, go ahead.
Okay. And the result is actually the MACE rate is just 1.4% in 0-1 care, and 1.7% experience MACE in usual care. MACE consists of the cardiovascular death, non-fatal MI. It does not include the index visit and unexpected intervention at the 30 days after index visiting. And we evaluate the non-inferiority to usual care. Based on the generalized estimating equation, 1.4% lower in usual care than the usual care. And this is a main result. And another result is just result of the 0-1 care. In rule-out group, now the patient was diagnosed with the MI. On the other hand, in rule-in group, just half of them diagnosed the MI. So we believe even in Asian countries, 0-1 algorithm really fit with the Asian countries.
And can I ask, chest pain is such a huge burden on at least the U.S. healthcare system.
Right.
It's very common cause of ED presentations, and it's a very common cause of serial testing and hospital costs. And so do you know from your numbers what percentage of patients were able to be ruled out at 1 hour and safely discharged home with a low rate of MACE?
In general, 50 to 6%, which is just consistent with previous report.
Yeah. Okay. Thank you. And then one question I had for you was anytime we hear a trial result, one of the questions we have is how does this apply to the patient that's in front of me? And so I'm curious to know, was there any differences in the performance of the algorithm in different patient populations? For example, patients with advanced chronic kidney disease, patients with advanced age, or patients with atypical or non-cardiac chest pain?
Yeah, that's a really good question, especially the renal dysfunction patient. Actually, we exclude the patient who underwent hemodialysis. Actually, the initial troponin level is actually higher than compared with the usual patient. Average of the initial troponin is in this study is just around 10. It's a less than cutoff level. But if you consistent of the patient whose EGFR just less than 40, just a study. But the most important point in this algorithm is just you also have to take care of the delta value difference between the 0 and 1 hour. Even though the first troponin is increased more than 14, but in case of the patient who do not have a myocardial infarction, will not increase the troponin level at the second level. That is why we can distinguish the patient, even though if you have a kidney dysfunction. And older age, it doesn't matter actually. It doesn't matter actually. Same thing with the patient with kidney dysfunction. Delta value can promise to let me know whether you are serious or not.
Yes. Okay. And so in summary, it sounds like there was a very high proportion of patients that were able to safely be discharged early with a low rate of 30-day MACE with a 0 1 hour algorithm. I guess the last follow-up question I would have is we always wonder about external validity and how this applies to other areas. We're finishing up at the American College of Cardiology conference. Do you have any thoughts on the externalizability or generalizability of your findings to other cohorts, whether it be European cohorts, US cohorts, or anywhere else in the world?
Yeah, that's a good idea. Actually, the cutoff level in the US is higher than that of the US or Japan, Europe or Japan. So that is the most important difference. But still, I believe there are algorithms that fit even in the US, of course, any country, because it is a Dr. Twellenbold who is from the Switzerland, and he is one of the authority to establish the Z1 algorithm. And they have already published the data using the Z1 algorithm in FDA recommended the cutoff value. That is why I believe this algorithm can adjust not only the Asian country, but all over the world.
Wonderful. Okay. Anything else you would like to add before we conclude?
Yeah, it's really good opportunity to be here. It's really exciting. So I really love the American style with Frank. So thank you so much to join this excellent opportunity.
Yes. Well, we're very grateful to have you. So this was Kenji Inoue, who is just going to be presenting in a few hours the trial results. And so we're getting a sneak peek here, fortunately, before anybody else is able to. For more videos like this, please check out our channel at youtube.com/FITsOnTheGo. And again, Dr. Inoue, thank you for your time.
Thank you very much.